This consists of 4 parts. The first one is an NGS in clinic. That is today, which will be given by Dr. Funk. Then Dr. Joan De Bono will be speaking on translational genomics and prostate cancer. That will be on the 28th of Jan. The third one will be on in February. That is by Dr. Clifford Weber Tepper from School of Medicine, UC Davis School of Medicine. And the last is Dr. Tishihara from Japan, from Hokkaido University in Japan. That will be on February 18th. Because if you are from Japan, then it will be at 8 a.m. on February 19th. So it's a slightly different timings. With that, so we are delighted to bring you this educational webinar series on NGS in clinical research. Now, NGS is increasingly used in clinical research, and there are often questions as what to do, how to do, where to start, and what is the latest thing that's happening. So in this series, we wanted to bring the experts in this field from different continents and share their experience of implementing next-generation sequencing in clinical settings. As you know, QIAGEN offers a complete set of solutions, starting from sample to insight. What does that mean? Sample to insight means sample is where we offer you the technologies for extracting your DNA or extracting your nucleic acids. And insight is where we're offering you bioinformatics, software, and curated knowledge databases to transform your data into relevant, actionable findings. That is what sample to insight means. The insights you gain may lead to one small step or a giant leap forward for science and healthcare. So partnering with QIAGEN can make a difference. So for more information, please visit us at qiagen.com. Before we move further, I have a couple of announcements. The first is the webcast is designed to be interactive, and we encourage you to ask questions during the event. Please submit your questions by typing it in the Q&A box that appears on the lower right-hand side of your monitor. If you have any technical questions or technical problems hearing or viewing us, please let us know by entering it in the questions box. Just to make sure that you can hear me clearly at this point, please enter a yes or no in the questions box. Okay. All right. Perfect. Thank you. So please use this box to ask all your questions. So with that, let me introduce you to today's speaker. We're extremely delighted to have Dr. Birgit Funk from the Harvard Medical School, who will be talking to us on NGS in clinic, a review of its impact on test development, operations, and result reporting. Dr. Funk received her PhD in molecular genetics from University of Würzburg, Germany, and trained as a postdoctoral fellow at the Albert Einstein College of Medicine in New York, where she identified the gene for 22q11 deletion syndrome. She subsequently completed a fellowship in clinical molecular genetics at Harvard Medical School and has dedicated her career to personalized medicine since then. Today, Dr. Funk is an associate professor of pathology at Harvard Medical School, as well as a director of clinical research and development at the Laboratory of Molecular Medicine. She oversees the clinical genetic testing for inherited cardiovascular and pulmonary disorders and was among the first worldwide to implement the clinical next-generation sequencing. Dr. Funk's current efforts focus on developing standards for gene and variant curation, clinical whole exome sequencing, and on developing approaches to promote the adoption of preemptive genetic medicine. With that, I turn over the presentation rights to Dr. Funk. Birgit, go ahead, please.
Okay. It's my pleasure to present this context to you today, and I want to make a quick distinction between clinical research and clinical diagnostics, which is what I focus on. We absolutely don't do research. We process patient samples clinically and perform NGS tests here. So that's the focus of my presentation. So let's jump right in. Here's a quick synopsis of what I'm intending to cover. I want to start with how NGS is used in the clinic today, and the focus will be on inherited disorders. So those of you who are more interested in somatic disorders, I'm sorry. Then talking about bringing NGS in-house, for those of you who have not done that yet, what are the main considerations, challenges, a little bit about the role of bioinformatics, and then I think it's important to talk about what NGS does not do well, and there's still, of course, a bunch of things. And the next bullet should be bullet 4, obviously. Time permitting, some real-world challenges. So if I have time, I want to end with a case example to point some of this out. So this slide, you know, I'm sure many of you have seen before, and it's just sort of to get into the subject matter and reiterate the disruptive nature of NGS. What's shown on it is the rapid decline of cost shown here per genome over the years, and in 2005 is when NGS entered the stage, first in the research setting, but then as costs kept declining and the technology became more accurate, only very few years later, the first clinical diagnostic laboratories started implementing it. It was about 2009. And you know, it keeps accelerating. The declining cost kept accelerating, as you see here. Today, I think it's fair to say that the majority of clinical diagnostic testing is focusing on NGS gene panels, but implementing exome and genome sequencing is also quickly increasing. So we'll touch on all of that. And just to show some real-world data of why NGS is so popular. It goes without saying, because you can sequence much more in parallel for a patient, and the detection rate tends to increase because of that. And what you see here is the effect for dilated cardiomyopathy, as we kept increasing the number of genes over the years. And this is actually data from that summarizes a whole decade of testing and starts way before NGS. In the old days, we just tested 5 genes and were hovering at a very low detection rate for that disease, 10% or so. And then all the way to the right is when NGS made its entry, and we jumped to 46 genes. And in the end, you know, we were able to quadruple our detection rate. So that's in essence why everybody wants to do it. And I'll try to give you a lot of reflections on you know, how to get there and what's good and what's maybe not so good. So which disorders benefit from NGS testing? That's an important question to ask, because it is still on the expensive side. And it's always great to use a real example. My personal specialty is inherited cardiovascular disease, and I think that is just a perfect example for it. Inherited cardiomyopathies specifically come in several flavors. There's hypertrophic, dilated, arrhythmogenic, right ventricular, and a few other more rare forms. They collectively are very common in the population. More than 1 in 500 individuals carries a pathogenic variant. And what makes them scary is that they can all lead to sudden cardiac death, and they all are now known to have a substantial genetic component, which makes for a great incentive for predictive testing or diagnostic testing if you're already affected. So here are the characteristics that make this a good substrate for NGS. There's locus heterogeneity. That means we have one disease, but the disease-causing mutation can reside in one of many genes. On top of it, there's allelic heterogeneity, meaning that either most variants are private, so they're scattered throughout the gene. We also don't quite understand the spectrum of pathogenic variation very well yet, and that's because these types of disorders have not been sequenced for a very long time. And then, really importantly, there's phenotypic overlap, which can complicate the testing process, as I will show you. Just to go through these challenges one by one, here's the locus heterogeneity for dilated as well as hypertrophic cardiomyopathy. On the right for hypertrophic, it's very modest. The majority of variation resides in 2 genes, but there is a smattering of less frequently mutated genes. So to be comprehensive, you really do want to cover those, even though the chance is less that you find a mutation in them. And for dilated cardiomyopathy, it's already more pronounced. There's at least the 1, 2, 3, 4, 5 major genes are shown here, but there's at least 15. And it's not as clear cut. So regardless, if you can sequence all of those in one reaction, that's preferred. As for allelic heterogeneity, shown here for hypertrophic cardiomyopathies, this is data from the last 10 years where we've been testing 11 genes, and it plots the number of variants and the number of probands we've seen these variants in. And as you can appreciate, the first bar here shows that 2/3 of all variants have been seen only once. When we started sequencing this disease 10 years ago, we thought, well, that would probably go away very quickly as we sequence more patients, but it still is the case today that the majority of variants are unique. So you really have no choice but to sequence the entire coding sequence of all these genes for maximum clinical detection rates. How about clinical heterogeneity? This is probably the most important point. And I want to start by saying that traditionally, molecular testing has been configured like this. We had one gene panel, typically with few genes for each diagnosis separately. And here's what that can cause. So this is a real case that came through our lab. This is on the right, you see the pedigree. The arrow shows the proband with dilated cardiomyopathy and a strong family history. So it's definitely genetic. At the time, we were asked to run the DCM gene panel. So as I said, there was, for each disease, we had a separate panel, and that was not NGS at the time. And we found a variant of uncertain significance, which is also very common. And then, because we had so many affected family members, we could do segregation analysis and track the variant and see whether it is present in everyone, which was not the case. Whoops, sorry. The variant did not segregate, which essentially told us that it's not causative. So that happens for many patients where you order a small restricted panel like that. Now the story went on. This patient was seen again. The diagnosis then was interestingly revised to ARVC because the two can actually present very similarly, and the physician now recognized that it actually is the latter. Now we were asked to run the ARVC panel, and we found another variant. This one was much more likely pathogenic and segregated perfectly with disease. So the point here is to underscore that this traditional testing, which was completely disease-centric, does not make sense at all for these types of disorders with clinical and genetic overlap. And just to show this again, this is how it was configured. We had one test for HCM, one for DCM, one for ARVC, and this is sort of a direct consequence of how these disorders were discovered, because naturally they were defined based on the most severely affected cases, which we know today are just the tip of the iceberg. As we've been seeing more and more patients, it is more appreciated that there is a lot going on under the surface, i.e. there's overlap, as you can see here, between all these disorders. So it is most common today for most diagnostic laboratories to offer multi-cardiomyopathy tests to take away the diagnostic burden from the physicians, and because as you just saw, it's easy to be wrong. And this case example I ran through is not an isolated one. We know today now that what I showed you for this family is true for about 3% of patients with DCM. They actually carry a variant in an ARVC gene. And then one other example from another disease area. Now we're talking about retinopathies, Noonan spectrum disorders. If you look at gene reviews, as recent as 2012, it'll tell you that almost 90% of patients with Costello syndrome carry a mutation in the HRAS gene. Now I'm showing you diagnostic data from our laboratory collected over the years, and you can see that it's the minority of patients that carry a mutation in the HRAS gene. So while they actually do carry mutations in other retinopathy genes in the same pathway. So most patients would have actually received a negative report if only this one gene had been tested. So to wrap this one up, there is phenotypic expansion. That's what what most of us call this today. As I said, the original clinical definition was based on severe cases, and that was often too narrow. We have phenotypic overlap that can lead to diagnostic error, if you will. And also, it's just true that genetic testing is really moving out of its specialty niche now into more general genetics care, and everybody isn't a specialist. So it's actually easier to cover these diseases more broadly, and this is widely recognized. I mean, I speak with several physicians here, and they're actually changing their workflow, which is the term that's being coined is sequence first. What you see here is the traditional workflow where the patient sees the physician, and the physician establishes a clinical diagnosis, comes up with some hypothesis of what this might be and which genes to order, and then you run through the whole genetic test and send the report back. What's happening now is that the diagnosis is deferred until the very end, until the molecular data is in hand, and then the clinical and molecular data are taken together to come up with a diagnosis. So next-gen sequencing has gotten very popular, and there's a big debate going on in the community right now, and that is, how far do we take it? If it's so good to sequence more, should we keep doing gene panels, or why not just doing exome? Exome sequencing is getting a lot better. So summarizing this here, gene panels have an important advantage, and that's they can yield very high coverage and therefore completeness, which is very important for clinically well-defined cases. If you think back to the locus heterogeneity, where I showed you the pie charts and the number of genes, when you know that your disorder has 2 or 3 main genes, you really want to make sure you cover them well, which traditionally was not the case on the right-hand side for exome and genome sequencing, and thus this tended to be more used for complex phenotypes or diagnostic odysseys, where lack of completeness was more tolerated. So, but I think it is fair to say that we're strongly pushing from here into the right side and are using exome sequencing more. And the incentives are obvious. A large fraction of these panels are negative. So even with all the benefits they offer, more than 50% of patients typically walk away with a negative report. I already covered the phenotypic expansion, and then there's just a cost argument, because additional testing, if the panel is negative, quickly ends up being more expensive than exome sequence anyways. And importantly, there's an accelerating pace of gene discovery today, and is very difficult to keep up to date. So clinical diagnostic laboratories developing and offering these gene panels are just not being able to keep up with that. There are some barriers, though. I'd say they're disappearing quite quickly. Cost has been always, has been made an argument, but that gap is really rapidly closing. And the coverage, the early exome tests were not very good, but that's also changing rapidly, and I would say the quality is quite good these days. But there's a big risk, and that is you can easily sequence more. That's not the problem these days, but you need to still understand what you're sequencing, and that is difficult to scale. In the old days, when we were only sequencing a handful of genes, they were handpicked and you knew them well, and that's as attractive as it is to quickly do an exome that has this type of risk. Because of that, there are a lot of community efforts to develop standards to help diagnostic laboratories and physicians. And I just want to quickly mention the ACMG and AMP guideline for clinical grade variant classification. That is for Mendelian disorders, very important. And then complemented by a large US-based consortium called ClinGen, the Clinical Genome Resource, that is set out to unite the medical genetics community by developing approaches to centralize and curate genetic data, not just variants, but now we're also talking about genes. Are these genes that we can now all of a sudden sequence Are all of them really disease associated? If so, which ones? How strongly? This is very important. So this is a new discipline. We've been classifying sequence variants for a while, but now all of a sudden we need to also classify gene-disease relationships. And that was completely unnecessary in the old days, because by virtue of having to restrict ourselves to these very small gene panels, we could only pick the most significant genes. So, and as we know today, many published claims for a gene-disease association don't withstand the rigor. If you really look, it turns out that this is a bit hyped up, and it's actually not worth sequencing this gene, because if you don't believe the gene-disease association, any variant in this gene cannot really be interpreted. So it's a big problem today. And the ultimate goal is to do this well, to establish clinical validity, to configure tests according to their use. So you want to be very restrictive for predictive tests. For diagnostic panels, maybe you would tolerate including genes with moderate evidence levels, but then genes with lower evidence levels, you really don't want to do for diagnostic sequencing, and can leave them for research. So that was a whirlwind for where we are today, and now I want to take a big step back and walk you through how to in-house clinical NGS, what's involved. So developing and validating a clinical molecular test has very well-defined stages, and they're not unique to NGS at all, but we're going to look at this from the perspective of NGS today. Probably the most important stage is the test design. And this here shows the so-called ACE wheel published by the CDC a few years back. The acronym stands for Analytical Validity, Clinical Validity, Clinical Utility, and Ethical, Legal, and Social Implications. And what I think it illustrates well is the complexity that that laboratories have to put in when they design and develop such tests. Followed by optimization, which for NGS is not that easy, or gets easier today, but it didn't used to be, because it's a multitude of steps one has to string together. Optimize if necessary, and then lock down the protocol, and then finally proceed into what we call clinical validation, and that is now to use the lockdown protocol to test the analytical performance of the test. And I'll talk about these 3 steps in a little more detail. The test design, for older tests with very limited contents, that was not such a big deal. But for NGS, where you can sequence lots of genes with lots of characteristics, this becomes quickly a bit of a 3-dimensional exercise. And let's walk through that. As for the contents, I already spoke about gene selection. It's a fair amount of work to establish clinical validity for all these genes. Also, you need to be very familiar with the gene characteristics. Is there homology? Is there high GC or AT? Because those can cause problems down the road. What types of variants do I need to detect? Is the gene known to have copy number variants, or is it all like small nucleotide variants? Is there mosaicism? All these will impact my validation strategy. You cross that with the technology you have in-house or you're thinking of buying, and there's the sequencer. What is the capacity per lane? How many samples can I squeeze in? What's the read length, and so on and so forth? What type of bioinformatics pipeline do I have? Can I detect SNVs and indels? Yes, most pipelines can do that quite well. But how about copy number variants or other structural variants? Because as we just said, some disorders might have a prevalence of copy number variants, so you may not want to use NGS for that. You end up having a technical reality check, looking at your operations. Because at the end of the day, I bolded that, it's all about test costs and turnaround time. So you need to look at your target size. How many kilobases are you sequencing? Marry that with your sequencer capacity and determine how many samples you can actually add. And then also ask, what sample volume does my laboratory actually receive? Now you need to, with these variables, you can come up with test cost and turnaround time and see whether that's acceptable. Then there's a couple of diagnostic reality checks. based on the gene characteristics earlier, a percentage of the gene might be unsequenceable. Difficult variants, as I said, might be prevalent, and am I able with my informatics pipeline to detect low allelic fractions that would be caused by mosaicism? We also have to do a clinical reality check, consult with domain experts. Now I might have found that there are a couple of really difficult genes. Are they critical? Can we maybe afford dropping them entirely or partially? Are there alternate assays offered elsewhere if they're critical? What is my required analytical sensitivity? You know, is the gene or the genes that I want to sequence, are they well established? Have they been sequenced for a long time? What is the bar I need to meet? How complete does the test need to be? All these things. And then at the end of all this, we come up with a development and validation plan. Now we know we might have to build additional supplemental assays when we have problem genes. We now need to go ahead and look for validation or reference samples reflecting different variant types, and so on and so forth. And importantly, also think about whether or not we want to fill in missing contents, because this is a very common strategy still in many laboratories to sequence via Sanger what doesn't work via NGS, and do we want to confirm variants? You can see that I could go on and on. These are just the most important factors to think about. And it really is also important to realize that there is no one-size-fits-all when you look at all of that. And I wanted to illustrate this showing you two difficult to sequence genes for which we came up with two entirely different solutions, and this is from our laboratory here. What you see here are the baseline characteristics, and they're very similar. One is a gene on the renal panel, the PKD1 gene. Another gene is a hearing loss panel, stereocylin. Both of them are essential for the disease. PKD1 has a very high detection rate. Stereocylin has only 10%, but given the hearing loss landscape, it still is one of the highest genes. Both are very highly homologous to other loci, so difficult to sequence, and have a complex variant spectrum. Now, how do we solve this for these two genes? Very different solutions. For PKD1, it does turn out that this is an extremely well-sequenced gene, so we shouldn't really do NGS knowing that it has problems with it. It also, luckily, has high clinical specificity, meaning that the clinical phenotype usually gives away that this is likely a PKD1 variant, and therefore we decided to drop it. The physician was perfectly okay because he said, I know when it's polycystic kidney disease, I'll just go ahead and order the other tests that exist in the community. Very different for stereocylin. This is not a well-sequenced gene at all. The clinical specificity is low, so it's not as easy to say, let's just keep it off and order another test, because the test doesn't exist and you wouldn't even know when to do it. So we kept it on the panel, but now we had to go in and develop supplemental assays, so a long-range PCR to get around the high homology to the pseudogene. We still ended up having a high failure rate for one long-range PCR product, and eventually dropped it for operational reasons. But that resultant analytical sensitivity drop was actually okay because nobody's sequencing this gene. So whatever we were able to do was fine. So let's talk a little bit about optimization. And I'm going to focus mostly on data analysis to illustrate some concepts. So this is now the entire data analysis pipeline that one uses for NGS, broken down into three phases: the primary analysis, which happens on the machine, the NGS run and the base calling, moving into secondary analysis, which encompasses alignment and variant calling, and tertiary analysis, which is then the annotation and prioritization, filtration, classification of variants in clinical reporting. And here's where I want to quickly underscore the immense role bioinformatics is playing, and that's, by the way, not just for NGS, but NGS has sort of focused our attention to it. If you look at, the three areas research, clinical development, and clinical operations, they all rest firmly on a bioinformatics and IT foundation. Nothing we do today is possible without a significant investment into these areas. So if you are starting an NGS lab, this is something you really have to take seriously. And to show how it evolved at our place, 2009, when we started working on NGS, we had two bioinformaticians, and when we launched, you can see where this went, and it's still growing. So what do we need to do? What types of things need to be optimized now in the data analysis stages? Going back to these phases in the secondary analysis, we're thinking often about coverage, so the read depth. There are other things, and I'll go through them. Strand bias, mapping quality, which is the confidence in the location of the read. Allelic fraction, the percent of reads containing a variant, and quality by depth. And tertiary analysis, there are many, many filters, but one that commonly used is the variant frequency, just to give you an example in control cohorts. So coverage, yeah, this has been well published by now. How much is enough? And I thought I'd give a quick visual of how to think about this. If you picture a candy jar with red and black jelly beans, and think about red being reads that contain a variant call, the jar represents the truth. So this is what the fraction of jelly beans that have this variant. But if you now go in and take a handful, how accurately will that handful represent this distribution? Well, it depends on the size, how many you grab. So a large handful will likely reflect the true 50-50 ratio. But the fewer you take, the more likely will you miss that. So, and you can see here that if you take very few, in 1.5% of the time, will you actually miss a red jelly bean. So this is the concept. So you can decrease the read coverage, but at some point you will significantly increase the chance of missing your variant. And that's been published in several places, and I'll give you one reference here. And the math that there's an equation you can throw at this: to be confident to identify variants with a range of allelic fractions, you need to be about a 20x to be 99% confident to detect your variant allele. That's what many in the community go by. Let's do a reality check. What does this look like in practice? So I'm giving you here a graph that shows the average coverage. This shows a coverage distribution for an NGS run. This is an old slide having two different Illumina chemistries. And you can see that we're sequencing for the red graph at about 400x average coverage for most bases. But when you go down to this part here, you see that a significant number of bases actually have zero coverage. However, it can be a little deceiving because 97% of bases in the test region were covered at greater than 20x, and only 3% had less than 20x. But if you think about what that means, these 3% can be distributed across several or many different amplicons. And if you really want to cover all these bases well, let's say by filling in via Sanger sequencing, that can be a significant overhead. So one needs to drill down into the specifics. If you want to offer completeness, then it can be actually quite costly to fill in even 3%. Running through a couple of other optimizations, here's a couple of examples for analysis thresholds. So this one here is about the allelic fraction. And what you see is the result of 200 or so samples that were sequenced. We found about 1,500 variants, and they were sequenced by next-gen sequencing as well as Sanger sequencing. When we launched our test, because we were so early on the market, there was no community knowledge of what to do, so we actually didn't have a threshold. We simply confirmed every variant we found by Sanger sequencing, and this is how we generated this data set. True positives are colored in blue, and red are false positives, het homozygous. And you can see that all the false positives fall below a certain allelic fraction that was 0.2. So we eventually implemented that, but you really do need large truth sets to be able to do this well. And until recently, there was none available in the community. So luckily, that has changed today. My last point here: there are some nice community resources one can go back to, and I want to point out one of them here in the United States, which is the National Institute for Science and Technology's standard NA12878. They use that to create high confidence regions and variant call sets that can be utilized for clinical work like this one. Quick point about allelic fraction thresholds. They are not the same for small nucleotide variants and indels. What you see here are distributions in orange for substitutions and blue for indels. And you can see that the allelic fraction observed for SNVs is a little bit higher than for indels, shifted to the left. And that's very explainable because the short read technologies still have problems with indels, especially the larger ones. They have trouble aligning that back to the reference genome, and in those cases, often they are discarded, these reads, and that ends up causing a lower allelic fraction. And finally, strand bias is this phenomenon where you sequence paired end, so you sequence your library fragment from both sides, and the variant is observed predominantly in one of the two read directions. That is called strand bias. It usually indicates a false positive, not always, but it definitely is a good metric to use as a filter. And finally, this is our most recent iteration. We're now using quality by depth and Fisher strand bias. These are Illumina metrics for those of you interested in that. And you can see same thing. Blue is true positive, red is false positive. And if you use large enough data sets, you can develop filters that are quite robust. All right. Part of the optimization phase is also to develop quality control steps. And this is for, from a regulatory standpoint, we have to do this. When we're inspected, inspectors will come and ask us, how do you identify a sample that is low quality so it doesn't accidentally get reported? And, walking through the entire workflow, there are numerous metrics that can be used. I'm not going to read them all. So what's the best approach here? Do you quality control each step? Do you do the process end to end? There's no one size fits all either. Both is best, actually. It is very important to test the entire process to see whether you can accurately detect variants, and you can use these reference materials that are available in the community. But it is also, from an operational perspective, quite important to identify samples that are likely going to fail, so you don't actually want to take them all the way through and find out at the very end when you've already wasted your sequencing reagents and so on and so forth. So two measures that we base our end-to-end quality control on is completeness and accuracy. So if you always run a control sample with it and you can see that you've reached your target sensitivity and your target completeness, then you're good. This is one example of a QC step. So in cluster density, it's also an Illumina phenomenon. And maybe I should skip over this a little bit. I hope the slides are being shared. It's quite self-explanatory because I want to get through the rest of the presentation. So very important is to determine your need for orthogonal confirmation of variants. What's shown here is old data from our laboratory. It was generated on an outdated technology. We're no longer sequencing at 50 base paired end today, but the essence is still true. You can see between substitutions and insertions and deletion variants that the false negative rate is very low for substitutions, And so is the false positive rate, and this is why we're worrying about it, because the chance of observing the substitution call with all the correct filters in place that ends up being a false positive is very low. Not so much for indels, where at the time we had a 15% false positive rate, and that tells you that you really have to go ahead and use another technology to make sure that you're not reporting a call like this out to the patient. So today I will say just a little addendum. NGS is actually deemed of high enough accuracy for single nucleotide variants such that many of us are now considering abandoning confirmation for this variant type. Now finally, test validation, the final step before launching a clinical test. There's been so much written and talked about this. What makes NGS different actually? Genetic testing, the first bullet is very critical. Genetic testing traditionally was synonymous with genotyping, so assessing whether a known pathogenic variant is present. Sequencing, on the other hand, is used to screen the entire coding sequence, and that enables novel variant detection. And this is the key difference. The core issue being that one cannot validate every theoretically possible variant. It's impossible. The testing process is also very complex, has many steps, and we have a new and unprecedented requirement for bioinformatic processing. And finally, the knowledge required for interpretation also doesn't scale proportionally, as I explained before. These issues, however, are not entirely new. They've existed with Sanger sequencing, actually, but they're of an order of magnitude worse. And so NGS has finally pushed the community over the edge and catalyzed this awareness and push for new approaches and standards. This is just to summarize the different performance metrics that one needs to establish in clinical validation. I will not go into all of them here. There's a bunch of references that do a great job. But just to pick out two, analytical sensitivity. So the way we approach this today is in a two-tiered way. The baseline is really to maximize the number of variants we're testing to achieve high statistical confidence. And unlike older guidelines that talked about genotyping tests, so that interrogated known pathogenic variants, pathogenicity doesn't matter at all here. It does need to be determined separately by variant type, and it is very critical to look at the confidence interval, and this is shown here. Focus on the two yellow rows where the sensitivity for substitutions is high, and is not terrible for indels, but you also need to look at the confidence interval, because despite the fact that we have 100% sensitivity, the actual confidence is not 100%. So that is important to calculate. And then we have to think about disease or gene-specific add-ons when, let's say, we're testing samples with, we're building tests that cover genes that have common disease-causing mutations, such as cystic fibrosis, the CFTR gene, where there are very well understood frequent pathogenic mutations in the population that we ought to include. Moving on to analytic specificity. The definition, if you look it up, is the ability to return a negative result when no variant is present. So we're now reflecting the frequency of false positives. And it's common practice, though not completely useful. And I would argue this is the wrong way of going about it, to count the wild type bases that are correctly identified as wild type. And here's an example. Say you sequence 20 kilobases via NGS and you find 5 false positives. That leaves you with almost 20,000 true negatives, and you use the formula above that gives you a specificity of 99.98%, which is terrific. Sounds really good, but what it really means is that you found 5 false positives, which is terrible, because that could be the number of false positives that go back to a single patient, given that 20 kilobases is very typical size of an NGS test, actually much larger today. So not very useful. Other metrics are more meaningful. One can calculate the technical positive predictive value, which is the likelihood that a variant is a false positive. You flip this formula around, shown here. You could also think about the number of false positives per test, and this is very important if a laboratory doesn't confirm variants. So this is showing the same concept again visually. The tier 1 validation being more methods-based. This is a term that describes the ability to string together results from different tests. You can do that. Let's say test 1, test 2, test 3, test 4, and you have different genes covered by each one, different numbers of variants. If you use this NA12A78 common reference sample that I described before, you're allowed to string together the performance across these tests, and that will help you to create a baseline performance with a tight confidence interval, at least for variants that you have many of. And tier 2, disease gene-specific considerations, what's in there potentially. The first category I covered, you might need frequent pathogenic variants. If you're talking about a well-characterized gene in your test, you might have one that has a high prevalence of pathogenic insertions and deletions, or other variants. You might have to specifically add some samples there, or you sequence a gene that is known to have mosaicism, so you need to add that validation component. That's actually not so easy sometimes, because if you're a laboratory that just starts out and hasn't been sequencing these genes for years and years, with other technologies, you can actually run into trouble finding the right reference materials. And that's a need that is currently being addressed by the community, trying to get together and really organize central resources, but that will take some time. One example of such a frequent pathogenic variant is a very common small deletion in the MYBPC3 gene, a hypertrophic cardiomyopathy gene that has a minor allele frequency of up to 8% in Southeast Asia. So it is known, though, to be dominant. It's very mild, but if you could picture, if you don't include that in your validation, particularly given that it's an indel where you know that NGS might have trouble, that would not be a good thing. So quickly moving on to what NGS does not do so well. There are some limitations, and I apologize for the typo here. Devil's in the details. NGS has problems with regions of high homology. That's well known. Repeat expansions, so some variant types are just not very amenable to NGS yet. Very large insertions, deletions, and copy number variants and other structural variants are tricky. That was less problematic for gene panels. Again, back then when we did small panels, testing labs had clinical domain expertise. We curated our content highly, and we really understood it. And we knew when we were dealing with a gene where this was the case, so we would then build add-on tests or cover this otherwise. And this knowledge doesn't scale. An example for genes with high homology is shown here. This is the gene I mentioned in the beginning, the stereosilin gene. It causes non-syndromic hearing loss. Very bad gene. The first half of it is 100% identical, including introns, to a neighboring pseudogene. And the second half doesn't look much better, actually. So if you look into common mutation databases, and this is the star here denotes a premature stop variant, which is annotated as a disease-causing mutation in HGMD, causative for deafness. This actually maps to the pseudogene. So this is what can happen when you sequence these genes without the accompanying knowledge, and that alerts you to the fact that you shouldn't actually be doing this. And that's widespread. Just to go through a couple of more important genes, CYP21A2 causes nearly all of congenital adrenal hyperplasia, Van Willebrand's disease, common coagulopathy. Very important, the PMS2 gene for colorectal cancer. Now, this is a gene that the American College for Medical Genetics recommends returning results to the patient regardless of the clinical indication that underlies the test performed. So, but to do this, you have to understand that this gene has sequencing issues, and so you don't run the risk of reporting back a false positive. All right. So I think I have some time to go through the case example I wanted to get to. Back to how do we do this in the clinic. And I want to add with a word of caution. I mean, I hope I've shown you that the NGS process is very complex. And even the best informatics and QC measures that we put in place do not replace a critical mind. So one needs to really watch out for results that don't make sense. A computer cannot do it all, and it's going to be quite a while until we're at that point. Here's my case example. We have a 9-year-old boy with suspected Noonan syndrome, and the test that was ordered was an NGS panel for that disease, so the Noonan panel, Noonan spectrum panel. That came back negative, and that was not completely unusual. The detection rate for this panel is about 70%, so we do see negatives all the time. What happened next? The physician did two things. A, they revisited the family history, and initially there was none reported, but now upon closer examination, they found 3 more family members that had some features, so that raised some alarm. And the physician then went ahead and ordered a whole exome, thinking, well, you know, the panel was negative, let's do an exome as the logical step. And unfortunately, that test found a pathogenic variant in the SOS1 gene, which was covered by our test. What went wrong? Was it that it was a variant in an untested region of this gene, or was the variant type not detectable? No, that was not the case. We do a very good job detecting missense variants, and we sequenced all the exons and regions. Was it a technical false negative? At this point, I received a very unpleasant email and a request to follow up, which we did. And we then went into our bioinformatics process, and this is a lot of stuff that you don't have to look at, but it's the output of our pipeline. And there is a section called common false positives, which we normally don't look at. It's what gets filtered out, removed from analysis based on all these metrics that we went through, strand bias and all these things. Now here in red is our variant, and it has a strand bias that was quite high. The highest strand bias value observed in our technical validation was less than 2. And we used a threshold of 20, figuring that we're extremely conservative, but ever so often something just comes through that behaves abnormally that you have not yet seen in your validation. And that's the key point. This is why we need to calculate confidence intervals and realize that even though we had in our validation obtained 100% sensitivity, it actually means that this is not at all unexpected. At some point you will probably look at a false negative. So they happen. There's little you can do about it. Oops. But what does need to be done is to be aware, and don't forget your clinical training, and look at the results and ask if they make sense or not. So I thought that was a good way of ending it. And I want to acknowledge all the many people who've contributed to this work over the years, and thank you for your attention.
Thank you very much, Birgit, for that very informative presentation. So before we start the question and answer session, I would like to remind the audience of how to ask your questions. So ask your questions, just use the questions box that appears on the lower right-hand side of your monitor. It says questions. So if you, so I'll just give a few seconds for people to start asking your questions. Anyway, let me ask you the first question. The first question is came from is how well NGS can help in pre and post treatment settings?
In pre and post treatment settings?
Yes.
Can you define this a little more? What do you mean by pre and post treatment settings?
This is from the audience. So
well, I can try. I mean, perhaps this goes back to the sequence first phenomenon. So pre-treatment. Oh, maybe the person wants to know about identifying treatments for disease. there is no general answer for that. If you sequence for patient for a disorder for which there are treatments available, then that can absolutely help. But I don't know. I have trouble answering this question right now. I'm sorry.
That's okay. So I've just requested the audience, whoever asked this question, to clarify, if you like, an answer for this specific question.
Sure. That sounds great.
Yeah, so please go ahead and clarify the question. Second is, which databases do you use to decide whether a variant is clinically relevant, or do you have a database built from your experience?
That is an excellent question. I wish I had time to go more into the interpretive side of NGS. So there is no good database yet. That is the problem. The community here in the United States is trying to build one called ClinVar. So it is in existence, and what it is intended to be is a repository for clinically interpreted variants. And the plan is also to, what's in place is a star system. So, you can, like in Amazon, when you have your customer reviews, we have a star system to designate how confident and how well established the pathogenicity of the variant is. Have experts agreed on that, and so on and so forth. So this is probably a good place to start right now, although has not been fully curated at all. And so, yeah, I mean, what we do today, unfortunately, is to do a massive data mining exercise and go to all possible databases that are out there in the community, and they differ by gene. Some genes have excellent locus-specific databases, such as the cystic fibrosis gene, very well curated, but you have to know about it, of course. And, it takes a lot of time. So for a laboratory going into this space, definitely need to put in a lot of budget for staff interpreting variants.
Okay, thank you. The next question is, currently, how many diseases do you routinely use NGS in your lab?
In our lab, we use it for about 4 or 5 disorders. They're all they all have the same characteristics as the cardiomyopathy example I walked you through. So we do it for hearing loss, Noonan spectrum disorders, connective tissue disorders, cardiomyopathies, myopathies. We just launched one for renal disease, and we have one for pulmonary disease. So.
Okay, thank you. So when you say this renal diseases and all the other diseases, so you have specific panels already for that?
Yeah, excellent question. So we're actually in the middle of transitioning away from fixed static contents disease panels because they're often quickly outdated. And the one example I have is for the pulmonary panel, which we built 2 years ago. And it was very sad to see that when we were finally done with this entire validation and optimization work, it was already outdated. So disease gene discovery had taken place, and there were actually a good number of genes we now should have added. And for that reason, we're now starting to use the EXOME as the underlying assay. We might still offer a targeted interpretation of only pulmonary genes, but we're no longer using a targeted capture for those, if that makes sense.
Would you in your case, what is the horizon for NGS to detect DNA methylation related problems such as imprinting disorders?
Yeah, so I personally don't have any experience with that, and I think most diagnostic laboratories that I'm aware of here don't use NGS for that, but I do think that there are solutions in place that, at least in research, but this is outside my area of expertise.
Okay. And the next question is regarding the diseases itself. Are these diseases highly pronounced in the US? Which other disease of importance are you targeting?
The diseases that I just mentioned are, have the same prevalence around the globe. So they're all very prevalent. Yeah, so other diseases to target, the sky is the limit. As a diagnostic laboratory, you typically work with your hospital and the hospital's needs, and we custom tailor our menu to our local needs, and then offer the test worldwide for if anybody from elsewhere wants to send it to us. But I think NGS is becoming relatively inexpensive, and it actually, I think, is beginning to replace Sanger sequencing. So anything really. I don't think there's, I mean, there might be some where you go like, well, it's really, let's say you want to have a sequencing test for achondroplasia, that is a disorder, inherited dwarfism, where there's only 2 pathogenic variants that recur. I would still not use NGS for that, but as soon as you're sequencing a couple of genes only, you might want to do NGS.
Okay. Birgit, can you please just move to the next slide?
Yep.
Okay. I just wanted to give the audience an opportunity. If we have any questions more, we can please send it to kayawebinars@qiagen.com, and we'll forward it to Birgit, and Dr. Funk will answer these questions. That is just for the announcement. We have some more time, so I'm going to ask a couple of more questions. For whole exome sequencing, are you not fundamentally limited by the use of commercial exome capture kits, which are known to be incomplete or imperfect?
Mm-hmm. Excellent point. Yes, I mean, that is true. Although I would say, so I personally helped co-develop one of the improved exome captures that's out there, and we tested that on many sets of genes for which we currently offer targeted panels, and the performance actually close to being equal, which gives us the springboard of moving these targeted gene panels off of their standalone captures onto the exome. Is it perfect? No, it's not. There's still gaps in there, that's true. But I think that is no longer a huge problem for at least the disorders we have looked at.
Thanks. Okay, we have time for one last question. So the last question will be, how do you estimate variant pathogenicity, especially for large genes like TTN?
Yeah, Titan is my favorite gene, actually. So, variant classification is a complicated process. For Titan, I mean, and there's a rule-based framework that is out there that we all adhere to by and large, which is the American College for Medical Genetics and Genomics has put that out with a good set of rules to follow generally. And you classify variants into 5 categories, starting with pathogenic, then going down to likely pathogenic, variant of uncertain significance, all the way down to benign. How do you do this for Titan? Well, this gene is one where truncating variants are prevalent and have been very convincingly shown to be associated with dilated cardiomyopathy. On top of that, for this gene, we're lucky that it's actually recently been well studied, and people have dissected a domain effect, so that it depends actually where you are in the gene, where that loss of function variant occurs. So we take all these factors into account. I mean, whoever's asking a question, you can email me. I can send you the relevant papers if you're interested.
So if you're interested in the paper, just send an email to either brcsupport@qiagen.com or kayawebinars@qiagen.com, and just say Dr. Funk reference papers in that case, and we'll send you whatever papers Dr. Funk is recommending us at this point. With that, I would like to thank Dr. Birgit Funk for taking the time today to enlighten us on our experience of implementing NGS in the clinical setting, and that's really very, very helpful. Regarding the slides, it will be available to you on SlideShare. You will get a link for that, and the recordings will be available within 48 hours on either on YouTube, either on qiagen.com or on YouTube, depending on how quickly we can upload it. With that, I would thank everyone for attending, and also remind you that we have the series. This is the first of the series. We have 3 more similar webinars from experts, so make sure that you can get a chance to attend that. With that, thank you very much, Birgit, again, and thank you all for attending today's webinar. Goodbye.
Bye.